Hello everyone, this is Alraies from CVI 2023. I'm really privileged to be with Dr. Rahul Sharma, who's been in interventional but structural mainly interventionalist for many years. Rahul, always nice to see you.
Thank you, good to be here.
So we're going to talk about a few aspects in structural heart, but definitely you presented a phenomenal case about challenging TAVR case, which is now rare to have these issues because becoming almost standard of care, but once in a while we get some challenging.
Yeah, I mean, TAVR is a commodity. It's become pervasive, and so many physicians in each community perform it. And the vast majority of the time, TAVR is very straightforward and no more than maybe a 25 or 30-minute procedure when you get into it. But every now and again, we come across cases that are more challenging, that require additional tools in our toolbox. This case that I presented this morning was a case that I'd done a couple years ago in which I had to use a snare to provide the appropriate support on the TAVR delivery system in order to deliver it to the native aortic valve in a case of bicuspid severe AS.
So what happened in that case specifically?
So specifically in that case, I basically advanced the valve through the snare and then pulled on the snare to pull the valve centrally to be able to get across this calcified aortic valve, which was heavily calcified and heavily stenosed. And the snares in general, I think, provide you a lot of opportunity to have more counter traction and support to navigate very tortuous anatomies or complex anatomies. And so having that skill set to use snares is very helpful, I think, in general throughout structural heart.
And what was your access for the snare?
Contralateral left transfemoral.
Yeah, 6 French.
Right,
snare.
6 French snare, 6 French R4 guide, 25 millimeter gooseneck snare, and then advancing the valve and everything through the snare in order to have the level of support to deliver the valve.
And that snare used just to give the traction to flex it more to get across.
Yeah.
Interesting. Yeah.
Exactly.
So I think it's easier to see it, to understand it.
Right.
But I want option for patients. So moving on to the right side of the heart. Tricuspid valve, we have a recent study trial in March, ACC, Triluminate.
Right.
But there's some good findings from the trial, but some disappointing or kind of unfavorable outcome. Let's go through the data and see when we can use this device.
Yeah. So, I actually look at it differently. Rather than thinking about disappointing outcomes, I have a different take on it. And I think it's a take that many, including Paul Saraja and others that were investigators in the study, have taught me as someone who has learned about this passively through some of these great scientists that led that study. And which is that, these patients with severe tricuspid regurgitation had no options. They weren't getting surgery, and they were being treated with medical therapy, which frankly was not working and does not fully work in terms of improving quality of life to a significant way. And so for me, the idea that the Triluminate study showed a quality of life improvement, but not necessarily a mortality benefit, is actually very understandable and relatable, particularly as I think about future commercialization of the TriClip and how to discuss this with referring physicians. I think about what do patients and physicians want to hear when they have patients that are very sick with severe TR. And what they want to hear, what those patients want to hear about as I meet them and treat them on my own, is that they want an improvement in how they feel. They want quality of life improvement. Okay. And if that's what the device can give them, then it's actually a win for the community in a subset of patients who had no other solution. So I think about talking to colleagues in the community and patients and their family members, not necessarily with the tune of, hey, this device is going to make you live longer in terms of tricuspid clip, but it's going to help you feel better. And feeling better for some people might result in being in the hospital less, possibly, even though there was no statistically significant reduction in hospitalizations in the study. But symptomatically, that means a lot to these patients who are struggling and going from hospitalization or doctor to doctor for the management of this chronic condition.
Yeah. Do you think the timing of referring this patient for these therapies is also crucial? Because as I remember from a protocol, it was left to the discretion, whatever the RV size is, whatever the tricuspid, as long as severe.
Yeah, so the anatomical characteristics and inclusion and exclusion criteria are obviously very specific to the anatomy and to the degree of pulmonary hypertension that's already present. I personally feel that if someone's pulmonary pressure is greater than 60 or 70, they probably will not benefit really in any significant way. And in the Triluminate trial, the cutoff, I believe, was 70 millimeters of mercury for the PA pressure. So from a community perspective, when we talk about patient identification, we want to clinically identify patients who don't have such severe pulmonary hypertension already, because they are even less likely to benefit. And then from an anatomical perspective, when we do a transesophageal echo on those patients or a transthoracic echo, there needs to be significant size of the RV and a lack of any kind of severe coaptation gap so that the clip can actually grab the leaflets.
Yeah.
So those are the anatomical characteristics that we as operators would have to tease out when the patients are referred. So I think about patient selection would be based on finding patients who don't have very severe pulmonary hypertension and patients who maybe are earlier in their disease course, where we can intervene and reset them on a different trajectory. A lot of times patients are identified very late when things are quite advanced, and I think those patients are not going to benefit as much.
So as you know, the tricuspid valve is, we call it like the neglected valve.
Or the forgotten valve.
The forgotten valve. It's because we don't pay attention to it. Don't you think should be some education to the primary care as well as cardiologists to refer them to somebody who does this procedure and when they can do that?
Yeah, no, absolutely. And I talk about this and think about this frequently with my physician colleagues in terms of how to spread that message. And I think, the first wave of investigators on the Triluminate study, many of whom I collaborate with and know personally, they've taught me that when you're going out there and talking to referring physicians and educating, I think the key is to just educate about the fact that severe TR leads to increased mortality. And you can fix the aortic valve, you can fix the mitral valve, you can treat coronary disease, but if someone has severe TR, they are on a different mortality curve. So to reset that curve, we need more work, more study, but to improve quality of life, we have convincing data from Triluminate that the device does that. And so, again, getting back to my earlier point, these patients had no other options. And the message to the community is these patients have very high mortality. We may not be able to help them live longer, but if we can help them feel better, it's worth the commitment. And so I think that is the message that I have learned in my early experience with tricuspid as far as how to resonate with referring physicians and patients and their families.
Is this therapy available or not available, approved by FDA yet, or is it in the process?
No, it's still in the process of FDA review, as we know, and I don't personally know, when approval would come, but certainly I think there's very convincing data from Triluminate that this is something that we need, that we can help our patients from a quality of life and symptomatic perspective. And hopefully we will have approval in the near future where we can put this to the test in a real-world setting.
Sounds great. Yeah. Thank you so much, Dr. Sharma, for your time. Please watch his videos and others on the CVI YouTube channel. This is Chadi from Austin, CVI 2023. Rahul, thanks so much.
Thank you.